having very good topics, which is useful for both our postgraduates as well as for practicing pediatricians. And before I introduce the speakers, I would like to call upon our State President, Dr. Jose, sir, to give the keynote address. Over to Jose.
So thank you, Dr. Beno. And today the faculty, Dr. Hazeena and Dr. Naveen Jain, sir, and our immediate past president of IAP Kerala, Dr. Jayaraman, Dali Madam, Suresh, Shobha Madam, senior faculty like Sehabalan sir, and other members joined to this platform. I think IAP Trivandrum, you do a wonderful job. I think every week they are conducting 2 or 3 academic program through Zoom, even though physically and Zoom meeting they are conducting. I think this week the IAP Trivandrum conducting the 3rd program for Sunday, Monday, Tuesday. They are regularly conducting academic programs. So whatever they conduct all the program in a very excellent manner with a very good academic fees for all of you joining here. I think today also we got an excellent topic with excellent speakers like Hazeena, and chaired by none other than the senior most neonatologist of Kerala and Dr. Naveen sir is there. So I think today with the wasting time we can start scientific program. I wish you all the best program. Jai Hind, Jai AP.
Thank you, sir. Now I'll give a small introduction about the speakers. The topic for today is early neurodevelopmental assessment in office practices. The speaker is Dr. Hazeena K.R. Madam is Chief Consultant Neonatologist at NIMS Hospital, Trivandrum. Ma'am is a practicing pediatrician for the past 18 years and neonatology for the past 12 years. Graduated and post-graduated from Trivandrum Medical College. And Madam did her fellowship in neonatology from KIMS Hospital, Trivandrum. Next, I would like to call upon our beloved, I would say our beloved, because most of the people who are attending the Tuesday series today would be sir's students. And he's none other than our beloved Naveen Jain sir. Sir is a senior consultant in KIMS Health, Trivandrum. And sir is the editor in Clohati Manual of Neonatology, Illingworth Textbook of Child Development, and sir had received the Best Teacher Award by the National Board. So now I would like to call upon our speaker for the day, Dr. Hazeena K.R., to start on with the session. Over to Hazeena, madam.
Good evening, Beno, and all my senior teachers and dear colleagues. So let me thank IAP Trivandrum for giving me the opportunity to present this topic before all of you, especially with the chair being our own Naveen sir, as Beno has put it. He is a great neonatologist and he is the editor of Illingworth and Clohati. So let me also thank all my teachers, especially one of the senior neonatologists of India has been my teacher, PMC sir, and also the doyen of child development in India, MKC sir. And I would also thank Professor Mohammed Kunya sir for teaching us basics of pediatric neurology. So without which I would not be able to do justice to the patients whom I see, as well as to the topic. So on to the topic, early neurodevelopmental assessment office practice. Am I audible? Am I clear? Shall I continue?
Yes, madam. Yes, madam. You're audible, madam. Please continue.
Okay. Okay. So let me initially itself state that this is not about NICU graduates. This topic is not about NICU graduates. It's all about normal newborns whom we usually see in our OPD practice, who do not have much risk factors, but are all of them developing normally? And are we able to identify or pick them up at the right point? If we are able to do so for the normal newborns as well, it would be a big preventive step and help the parents and babies whom we are seeing. Now, how early is it possible? It is possible as early as newborns. And I would say that if by early infancy, before 6 months, if we can recognize problems in newborns, it would be help in initiating the early stimulation and early developmental therapy, and thus help in preventing further morbidity. But isn't it time consuming? Yes, it could be time consuming if we go just by the structured way. So we need to go towards a functional or targeted approach has to be taken, especially because we get hardly 3 to 5 minutes to examine a baby. Now with that, we'll go to a first case scenario about a normal newborn with birth weight 3 kg. Baby was feeding well, and in the first visit, baby looked normal. For the vaccination, the first vaccination visit also, baby looked normal. And at 2.5 months, they said that baby's social smile had appeared, but we noted that head lag was more for the baby. It was not appropriate for the age. So we initiated therapy for the baby, and it was continued for 2 more months with no results. At 4.5 months, this baby was having poor feeding, poor weight gain, tone looked still abnormal, head control was not there, but social interaction was good, evaluated. And finally, with genetic evaluation, we found out that there is a mutation which was resulting in methylmalonic aciduria, which is autosomally recessive disease. Actually, it is not a disease which we can cure, but then we could offer genetic counseling for the parents. And the second and third baby, the fetus also had the same problem, because they could do amniocentesis, targeted amniocentesis and genetic evaluation. But now the fourth baby is doing well. Baby was born just 3 months back. So what are the developmental concerns that we usually note while in OP? It could be just delay or a variation or a deviation from the usual trajectory. There could be no progress in the developmental milestones. It could be regression or dissociation of the different domains of development, tone abnormalities, vision, hearing, speech, interaction, communication, or behavioral problems. Then it could be the neurological illnesses, the neurometabolic disorders, dysmorphism or syndromes, or congenital structural anomalies of the brain. Now, when we say development assessment of a newborn, I would stress that it should become part of all pediatric visits, which has been taught to us by all our teachers. Always there should be a developmental history taking and developmental assessment for all pediatric visits. And we should use and modify our observation skills and improve our observation skills and communication skills. And we should always try and keep our eyes, ears, hands, and mind open to look out for any problem. And when I say development assessment, it should never be a single assessment. It has to be done over 2 or 3 visits, multiple visits. Only then we can be sure of a problem. It should be a longitudinal process. This will help us in early detection. Now, when are there factors which can be modified? I mean, which can cause variation in the development? Are there modifiable factors which can cause variation in the development? Yes, definitely there are modifiable factors like parenting, the environment, the nurturing. So as pediatricians, we are supposed to not only observe the babies, but observe the parents also, because we usually notice in the OPD that some parents are not listening to the cues of the baby, not talking to the baby, or some parents may be just holding the baby's neck even when the baby is 3.5 to 4 month old or even 5 month old. Some parents might be holding the baby in a little awkward way while feeding. They may not be changing the position of the baby even when the baby is demanding. Sometimes we need to ask whether they are concentrating on their mobile phones or doing some other course when attending to the baby. So if we observe these things, we should actually talk about these things to the parents and advise them to change their pattern of parenting, and we should also advise them to do gentle rocking of the baby, swaddling the baby, wrapping the baby properly, massaging from head to foot, all parts involving, and gentle exercises involving all the joints, which makes range of movement possible. So parenting and nurturing should also become part of our examination. I mean, where we can counsel them. And at least 1 second we should take in our OPD to ask about sleep issues, which could take longer time for sleep onset, which could be like taking longer time for sleep onset, excessive cry, intermittent waking up, sleep solely on hands. Mostly these are behavioral issues which the parent and the baby will overcome with time. But if there is inconsolable cry, if the baby cannot be settled, if there is only few hours of sleep, then we should keep in mind and correlate it with other clinical history and examination. So when I say examination, I'm just concentrating on the targeted examination. Always we can examine the baby either on the lap of the mother or parent, or on the bed, but the head has to be in midline while doing a neurological examination. Head circumference measurement is mandatory in all visits. Serial measurement is important, and it has to be plotted against the head circumference chart. And along with this, we should observe the anterior fontanelle, observe and palpate the anterior fontanelle, the posterior fontanelle, and also for the sutural overriding and the widening of the sutures. And we should never forget to examine the presacral dimple, or a sinus, or the presence of tuft. Now, this is one of the commonest complaints that parents ask about. When you look at the shape of the head, plagiocephaly, this usually occurs when because the brain is rapidly growing, the skull is rapidly growing, and a constant pressure is coming from below. We should advise parents regarding the change in position of the head when they are lying down. This usually is seen in NICU babies, but then some term babies also come with the same complaint. So we should advise them regarding the position of the head, change in position of the head on either side. It is, even if we pick it up at 3 months to 5 months, it's actually preventable with changing position of the head. Now, this is something which we should never miss. That is the Erb's palsy. If we get a history of shoulder dystocia and a large baby and paucity of movement of the limb, we should examine for clavicle fracture as well as Erb's palsy. There could be Klumpke's palsy also, where there is the clawing of fingers may be noted. Now, another OP usual thing that we pick up in the OP is torticollis. This is usually because of the abnormal positioning in utero or abnormal holding of the baby after the baby is born. And at 3 months of age, when the baby is not sitting properly on the lap with slight head tilt, we should notice it and help the parents and counsel them to keep the head in a straight position. If already torticollis has set in, physiotherapy has to be advised. Otherwise, it can cause problem with the later posturing. Now, coming to the cranial nerve examination, as we all know that in babies, we cannot do it in a structured way, but then we can do the examination, the face, the facial expression, not only during sleep, but also during awake state. And whenever the baby is crying or smiling, we can look at the face and see whether there is any involvement of the facial nerve. Also look at the shape of the palpebra, the shape of the eyes. Then eyes, we look at the movement, whether the eye following is there, whether the eye movement is complete, then pupillary reaction, and also the vision. Ears, auditory response has to be checked. And and about the sucking and swallowing. Even though this is a survival response, this is there in all babies. There are babies who show a problem during the initial period of feeding. Most of the time we might take it as feeding difficulty when we counsel the parents regarding the feeding issues, but we will be able to pick up some neurological problem by just observing the babies sucking, swallowing. Sometimes this could be normal, but continuously baby could spit out, drooling will be there. So in cranial nerve examination, with the observation of the face, the shape of the eyes, the pupillary response and the eye movements and following, as well as the vision and auditory response and sucking, swallowing reflex, we will be able to assess the cranial nerves, which can be done in few seconds time. Now let me talk about another case where a 2.5-month baby was brought with complaints of eyes. There's no fixation of eyes. Baby didn't have social smile, no face regard, no following, and eye evaluation was done, which was normal. So we advise them visual stimulation with black and white pictures and also the human face. That is the maternal and paternal, as well as the grandparents. They all started talking and communicating with the baby. Bright objects were shown and torchlight covered with bright color paper was also used, and did the other development therapy as well. After a month, baby developed eye fixation, face regard, and started following objects, and social smile appeared after 1 more month. So this is actually nothing but delayed maturation of a milestone. So for visual stimulation, the most important thing that we can advise is human face. Then black and white contrasting pictures like this can be used in OP, as well as we can advise them to be used at home. Now I talked about feeding already. After cranial nerves, we have to observe the posture of the baby. Posture of the baby is very, very important. We know about the frog-legged posturing as well as the cross, the scissoring of the limbs. In between this also different postures will be there, according to which we will know whether the baby is normal, abnormal. So it's mandatory that we observe the posture of the baby. Now, next important thing that we should observe is movement, the quality, quantity, and symmetry of the movement. This is a video which shows the movement of a baby who got admitted in our NICU with complaints of poor feeding. The poor feeding was just for which they bought the baby, but the baby's this is a 55-day-old baby who came with poor feeding and poor activity, and poor weight gain. Sorry, I don't know whether the video. Yeah, please look at the legs of the baby. It is not moving at all. The upper limb is having paucity of movement. Lower limb is not moving at all. Baby's facial expression is also not good, and there is hypertonia, which we can make out in the baby's position itself. The quality, the quantity, but here the symmetry looks good. That has to be assessed. Now, while the baby is lying down itself, we can check the Ameltisen ankle. I will not go into the details of the ankle, but we should check the scar sign for the upper limb, the dorsiflexion angle, the popliteal angle, and the adductor angle. All these angles has to be measured. At least one of them, adductor, we have to see for the lower limb, and scar sign we have to see for the upper limb. And regarding the tone examination, so that was about the tone examination. Again, about tone examination, we can do the vertical suspension and see whether the baby is slipping or crossing of leg is happening. If slipping, it is hypotonia. Crossing of legs indicate there is hypertonia. And for ventral suspension, when you do ventral suspension at around 4 weeks, the child can hold the neck along with the straight line with the back. By around 12 weeks, baby will lift up the head. You have to look at the limb position. Normally it will be flexed, whereas if it is extended, it indicates extended, and head floppy, it indicates it's a floppy baby. And then you can have the pull to sit examination, where you look for the head lag, as well as usually even in newborn baby, there will be a slight shoulder elevation. The baby takes the head along with, and then it goes back. So we know that there is the tonus. Okay. Along with that, baby will give a slight traction at the elbow joint, whereas we usually do not see such thing in a hypotonic baby. And in hypertonia, age inappropriately, the baby's head control will be there. Earlier itself, baby will come up with the head. So this will help us in evaluating the tone of the baby. Now, coming to the neonatal reflexes, there are umpteen number of neonatal reflexes, but we'll just concentrate on Moro, palmar grasp, and ATNR. All these reflexes, if it passes beyond 3 months, it is abnormal. Regarding the palmar grasp, we know that we should approach the hand along the ulnar margin. And about the ATNR, if you turn the head to one side, there will be extension of that side and flexion of the other side. And Moro actually is a very important reflex, which we have to do it in a general way. Usually neonatologists do not say that, I mean, do not allow people to do a Moro because it is actually a cumbersome this thing. But if you do it very gently, you will know almost all the symmetry of the baby. You can elicit the crying of the baby also. And regarding the tools, scales, and scores, which are used for clinical as well as research purpose. But as practicing pediatricians, as clinicians, we need to apply the scores and scales based on clinical assessment, the history, the home environment, and parenting. It could be time consuming, but thanks to the Trivandrum development screening chart developed by our own MKC sir and his team at CDC, we can use it in office practice. Just the PDF and the transparent scale is enough to assess the baby. You use the transparent scale and keep it along the y-axis at the particular age. If it is a 3-month-old baby, you keep it at this point, and all the rectangles which has been completed before 3 months has to be, which stops before 3 months has to be completed, which is continuing, we can give time allowance. So that is it about PTSD. And then Hammersmith neonatal neurological examination and infant neurological examination is there. This is basically what I was telling earlier. That is, you would check the cranial nerve function, you check the posture of the baby, the movement of the baby, the tone of the baby, the reflexes of the baby. And there are 34 items, but we cannot do it in a in an office practice. But at least if you check the cranial nerve function, look at the posture, the movement, the quality, symmetry, and the quantity of the movement, and the tone examination by checking the Amel-Thiessen angle, the popliteal, the adductor, and also the scarf sign, and then having a ventral suspension and pull to sit, and checking the 3 reflexes which I mentioned earlier. This will take hardly 1 to 2 minutes to complete. So let us see another case scenario. Where we had a low birth weight baby with feeding issues. We thought it is the mother's problem itself. Baby is not being handled properly. So we kept on counseling them. And on day 4, because the mother also was not comfortable, the baby is also not feeding well, we thought we will give more counseling. So we went and took the baby on our hand and found that this baby is having inconsolable cry. The posture is abnormal, tone is abnormal, and while we kept the baby on the bed, and baby was showing some kind of writhing movements which were not symmetrical. Actually, this baby, because of that, we didn't discharge the baby, and the TMS report we had sent on day 2. We called them and asked for a rapid report. They sent it to us on day 8, and it showed maple syrup urine disease. So with that comment on writing movements, I will talk about general movements. Actually, it was put forward by Prechtel, I mean described by Prechtel. Maybe our grandparents might have described it even earlier. These are actually distinct spontaneous movement pattern which appear prenatally and last up to 20 weeks. Up to 10 weeks corrected age, we see the writhing movements, which actually starts from one limb, goes to the other. This is what we usually see in babies when the parents complain that they remove all the towel which is kept on top of the body. They are not liking to be covered. Those kind of comments come from the parents because of this writhing movement. But after 12 weeks to 20 weeks, the movement is fidgety. It is just the tiny movements which start in the neck, then in the chest, then the spine and the abdomen. Baby keeps moving like that. Those are the fidgety movements. So writhing movements are seen up to 10 weeks, and after 10 weeks to 20 weeks, fidgety movements are seen. Maybe we will not be able to see such movements in our OPD, so we can advise the parents to bring in a video. For writhing movements, we need 10 minutes video, and for fidgety movements, we need a 3 minutes video. We need to advise them that it has to be a drone kind of picture, that is from above. We have to take the photo, and baby should not be stimulated while taking the video. This is a video of a writhing movement of a baby. Okay, that's it. Now, fidgety movements, serial photos also can be taken, and studies have revealed that if the baby has fidgety movement, in spite of having MRI abnormality or ultrasound abnormality, babies will develop normally if they have normal fidgety movements. But if it is sporadic, if it is abnormal, if it is absent, then it could indicate that the baby is going in for cerebral palsy or later genetic problems. If unspecific kind of, we can't describe the fidgety movements, it could also mean that the baby can go in for cognitive problems or later on autism. So with that, let me ask a question, whether babies have emotions and do they show behavior? Yes, definitely they have emotions and they show different behavior. Just like we adults do have temperament, babies also have temperament. They are highly reactionary kind of babies. They are very calm kind of babies. Most of the time we see in OPD, babies who are brought to us with colic. It could be abdominal pain, it could be ear pain, it could be other problems. But then there is a concept, there is a fact that baby has a particular temperament which needs a little time to settle. Usually it settles by 4 months. That is actually the time when the parents get to interact with the baby, and the baby gets to interact with the parent and understand each other and adjust with each other. So crying is baby's language, and it should elicit an appropriate parental response so that it will modify both parental and child behavior. Now, because we talked about behavior, we should have one word about Brazelton Neonatal Behavioral Assessment Scale. It tests 4 distinct areas: the interactive behavior at the home, that's the social behavior; the motor behavior, which we already talked about, the reflexes, the tone, the muscle activity, the posture, and also the control of physiology, that is the baby's ability to quiet himself, to self-regulate himself. We see often babies who start crying for feeding, but if the mother is not coming, baby will take the hand to the mouth, the hand-mouth coordination, and baby will settle after a while. So that ability, the consolable, cuddleable, and the self-quieting nature, and the startle reaction. So high score will indicate neurologically well baby, and around 28 aspects of score, which are clustered into 7 categories: the habituation, which is the response decrement to the light, and orientation, and motor performance, then range of state, the sleep state and the wake state of the baby, regulation of the state, autonomic regulation, the neonatal reflexes. And I will have one word also about whether we can identify autism early on. We cannot diagnose autism. It can be diagnosed only the diagnosis comes at 1.5 years only, but then there could be some early signs which are shown in infants, like unusual visual fixation, abnormal repetitive behavior, lack of age-appropriate sound development. They may not have that dada mama sounds, the babbling will not appear, they may not respond to call, there is delayed intentional communication, and they are not trying to get parental attention, decreased interest in interaction. So if these kind of things are shown, then we should keep a note of this baby and keep the baby under follow-up and therapy, so that we can at least try and prevent, we may not be able to prevent the development of autism, but at least delay the onset or reduce the severity. So as pediatricians, our role is not to let babies fall into neurodisability, act as a safety net, always do a short screening of all babies who come to us, and advice regarding the exercises, the massage, the stimulation that has to be done on the basis of the developmental age of the baby. And we should make parents the therapist and review for further assessment, do evaluations as and when it becomes necessary, and never ever ask the parents to wait and watch. So with that, that's it. Thank you. Thank you. Hope I did justice to the topic, but without demonstration, this may not be a complete one, but I hope that I could get across the idea that even in normal babies, we should continue to do developmental evaluation and advise parenting behavior, so that we can either prevent or not allow them to fall into problem cases, neurological disabilities. Sir.
Yes, Hazeena, like always, your presentations are a song, and you have taken us through, within 30 minutes, you have taken us through so many aspects of what we might see every day in our developmental practice. The forum belongs to the audience, but I will just repeat one word which our own guru, Dr. MKC, who is a man of simplicity, who says that 2, 4, 8, and 12. At 2 months, if a baby has not smiled, like the case which Hazeena presented, please, this is one message to all of our friends. Please don't say it's okay, let us wait and watch. Question, but 2 months baby should smile. At 4 months, baby will have head control. Of course, if you look at the CDC grading, you will be able to interpret the head control more correctly. Otherwise, there will be bias or a error in interpreting, but a head control should be there. 8 months when they come to your OPD, maybe they come at 9 months for vaccination. Please have them sit on your table. See whether baby can sit with a straight back, pivot and look around. Play without fear of falling down. 12 months, even if the baby cannot stand independently, make him stand by a chair. See whether he pushes the chair around confidently, both in left and right side. You will exclude all hemiplegia and other problems. If the child is even having toe walking, if he can briskly move around with the chair, he is not going to develop diplegic CP. Dr. Hazeena, that at least 2, 4, 8, 12, if you do, we will not miss major issues. And of course, Hazeena highlighted the importance of head circumference, weight gain, everything was there. I wouldn't just repeat what she has said. Over to Bennu and Hazeena.
Yes, sir. Thank you, sir. Hazeena ma'am, can we move on to the questions? There are a few questions in the chat box.
Yes.
Okay. Madam, first and foremost, many good comments about the presentation. It was a wonderful presentation. And
Thank you, Bennu.
yeah, by Dr. Maya Menon, can pediatricians advise therapy, or is it always necessary to refer to a developmental therapist? Can pediatricians advise therapy, or is it always necessary to refer to a developmental therapist? If there is any.
Pediatricians can definitely advise therapy, but then pediatricians can definitely advise therapy. I was talking about the normal newborns. If there is, if there is problem with the vision, if there is problem with the hearing, we will have to take a multidisciplinary help. But then there is no problem for advising therapy, because we can advise regarding the visual stimulation, the hearing stimulation. We can talk about the oil massage that has to be done on the baby, the gentle exercises that has to be done for range of movements, and also improving the tone of the muscle. If you notice hypotonia, these therapies can be advised by pediatrician, but at the right time we will have to take the help of other departments as well, which has to be given to the parent and the baby. I hope I answered the question.
Yes, ma'am.
Sir?
Yeah. Naveen sir, anything to add upon?
I will go with Hazeena completely, that we have sometimes misconceptions about therapy being some major thing being done in the form of people giving a special device or a special program of how to do intervention, or sometimes we think it's an occupational therapist busily spending time rolling a baby on a ball or making him hang from a swing. It's not like that. Most of the development which is modifiable, the keyword which Hazeena used is modifiable, involves a lot of lack of what is called mother and baby or father and child dyad interaction. So if you play with a child, the child will play back to you, and then you get excited, and then again you get more energy. But if the child is not the kind who is responding to you, you get demoralized and you do not do much. You are not the same parent who was expecting a healthy child. When you get demoralized, then you are not giving any signals or stimulus to the baby. And the opportunity for baby to improve from that negative or from the low score becomes even poorer. So that is where you come in as a doctor and try and tell them even the simplest things that they wouldn't do. Talk to the baby, play, toss him around, take him around the house. So modifiable early intervention, telling the parents simple things can be started. And of course, when you pick up a pathological condition, you need to involve a clear diagnostic plan. There also pediatrician is a role. I still feel there are questions which are asked in conferences that who should be the center of all therapy? Should it be an occupational therapy department or pediatricians? I am very clear it has to be pediatrician. You may send to neurologist, but they come back to pediatrician and then he tells what to do. You send to an ophthalmologist, he comes back to you. So you remain the heart of the whole connection process, where you explain what is happening, decide what tests need to be done. A motor delay can be hip displacement, it can be cerebral palsy, it can be just a delay, and that a pediatrician can pick up sometimes much more than anybody else can. So definitely the first intervention process starts with us pediatricians.
Thank you, sir. We'll go to the next question. Parents try to keep the baby's head in midline using pillows. Is this necessary?
Yeah, usually parents try to keep the baby's position in midline, which is neurologically correct. But then there are situations when you keep the head in midline and the baby develops a vomiting sensation and the baby can aspirate it. So usually we tell not to keep it tight as possible so that baby cannot, they keep it so tight that the baby cannot shift the head to either side if vomiting sensation or such problems or coughing, those kind of things come, baby can aspirate the feed also. But then keeping in midline is actually good, but then so much of pressure should not occur from the back, which can cause brachycephaly. Otherwise, if the baby's head is, and also we should advise regarding the change in positioning. That is more important. Like we can put the baby on lateral position on either side so that the pressure will be equalized on all the sides.
Naveen sir, anything to add?
Yeah, I would like to pass on the question after just one comment, is that healthy babies like to keep the head to one side, and grandmothers over last tens of generations have tried to buy mustard pillows and UV pillows to try and put it in the midline, but the babies always succeed in keeping it to one side, and most of them develop plagiocephaly. In the US, they use helmets, tighten the screws, but I think it is really no abuse is meant, but stupid. And babies would roll after 4 months and have the head back in shape.
Yes.
But if you do pick up a D-shaped head in a baby who has a developmental delay, then you must wonder that he is lying like that, like we see in Down syndrome, what we call as brachycephaly, where the back is flat.
Yes.
It is because the baby is not moving around at all. So in a preterm baby, like Hazeena said, it can get exaggerated.
What sir said, as Hazeena madam told, in those babies who are neurologically abnormal, they tend to keep the head straight and the movements will be less. Allow the natural course, I think. So that means the baby will move the head from one side to this side to that side. It's a normal course. Even if plagiocephaly is there for a normal baby, it will correct by itself. So I think allow the natural way. If it is abnormal in the preterm baby, you can get exaggerated plagiocephaly. But if it's a term baby who's keeping the head in the straight position and developing that, it's a concern. That's from my point of view.
Okay, sir. Sir, Naveen sir, shall we move on to the next question or?
Yes, Venu, please do so.
Okay. What is the significance of toe walking in a toddler? What is the significance of toe walking in a toddler?
Okay, toe walking usually means there is tightening at the Achilles tendon. It could also mean that there is more of plantar extension, and usually the parents tend to use the walkers. There are so many people who come to OPD who say that they have started using walkers, which will help the baby to walk earlier. But then that is actually a contradicting statement. Walkers usually delay walking. We should advise them that should not be used, because the message that the baby gets is as the walkers are used with the wheels, they are moving and they just touch the toes on the ground and they get the message that this is how walking is done. Stepping need not be done. So that is one thing that we need to advise. And second thing is, it indicates that there is problem with the tone. So we need to put such babies into for exercise and therapy.
Naveen sir.
Yeah, I will just agree with Hazeena and add on one thing, that for reasons that we don't know, many children between the age of 1 year and 2 years, and sometimes even up to 3 years, tend to start walking toe when they get excited, when they want to run.
Yes.
But remember that the toe walking is a is a pointer or a marker to motor dysfunction.
Yes.
And if the child can run without falling down, then there is no motor dysfunction. That is the function. That is the function. He's doing it. So if a child, parents come and say he's running, and when he starts running, he tends to toe, gets excited, then tell them to wait for some more time. If he doesn't tend to fall down. And similarly, when you allow him to just play around for some time, if the towing is there for some time, but on the other times he tends to take the weight fully on a flat foot, then he is not having a pyramidal sign. It is just that pyramidal features which are there in the infancy in 1 year, which are continuing in some children during excitement. So in a child who has dysfunction and toe walking, that means he has delay in standing. 1 year, he doesn't stand independently, you make him stand by the chair. There also he tends to fall backwards, or he's very unstable near the chair. 1 year, 13 months you call them, he still can't be stable by the chair. He tends to fall off. He can't push the chair around, and he's walking. This child has a problem. But another child who tiptoes like in a Tom and Jerry and walks toe on toes, then he's just a little naughty guy. And this is my personal opinion. Dr. Jayaraman sir is there. He has a lot of experience in handling children in intervention centers. So your comments, please.
Jain sir.
Yes, thank you, Naveen. I do agree with this. We see so many children with this problem, and as you told, very often it becomes a clue for some motor dysfunction. That's what we see in practice. And as Dr. Hazeena was telling, Walker is very often one of the causes which we see, which gets corrected over time. Regarding the other, that placing the child head in the midline, I feel it is something which is not necessary, and it is better to allow the child to follow the natural course, because this is a common problem which we see in our routine practice, also a common doubt which we had to face. This is my opinion regarding these two questions.
I agree.
Naveen sir, shall we move on to the next question, sir?
Please, Beno.
Next question is by Dr. Fairy. Is waiting for 1 month for delayed maturation justified, or should we just straight away start therapy?
I would say we should straight away start therapy, Fairy. Even if it is, even if at the point when we notice a delay, we should not waste time. We can advise, we ourselves can advise the therapy and let the parents do it, and we can do a frequent follow-up to see whether the baby is developing normal.
Naveen sir.
Yeah, I would just confess that when I was a pediatric resident, I did not read my textbooks. I just tried to pass my exams. But when they made me the editor of Illingworth, I was forced to read every word of what the great guru has written. So there is a chapter in that called Normal Variations in Development. I think all should read it. And he has alluded to different domains and how much variation can be there in each domain. So, for example, if you find a baby who is not having social smile at 2 months, it's extremely worrying. Not even a week waiting. But if you see in the OPD, you will see a child walking at 12 months, another child walking at 15 months. Even in my house itself, my daughter, who is a girl, walked at 14 months and started speaking at 11. And my son, who is a boy, of course, and he started standing at 11 months and started saying first meaningful words at 17 or 18 months. So there can be gender variations, there can be person-to-person variation in motor milestones, and even language milestone depending on stimulation at home. So I would just pass on this question to say, please read this chapter called Normal Variations, and that would answer Fairy's and Haseena's points clearly, that in some conditions it is urgent, like in a social smile. In some of them, which can have variation, ask family history, ask for opportunity given to the baby at home, and they may then help you to whether to jump or not. And in the presence of risk factors, like a previous child affected or the baby being asphyxiated, your worry and your concerns may be a little more heightened, even if it is overdone.
When I said therapy, I actually meant we should advise the parents to do the stimulation at home. That has to be continued. We need not refer the baby for a different therapy center or do all the investigations. But as Sir told.
Yeah, I fully agree with you, Hazeena. I was just trying to
Yes,
say
I
that
understood, sir.
our guru is having said that different domains have different variations.
Yes.
Yeah.
Anybody wants to comment on or give their opinion regarding the same? Thank you, Ferry, for that question. I think all of us will go back and, as Sir said, we'll go back and read. I think this is a repetition. Are pillows necessary, madam? Back to sleep program now states that no extra things should be put on the baby's bed, if I'm not wrong.
Yeah, soft items are not recommended.
Okay, fine. So, madam, next question. How frequent is congenital dislocation hip in Kerala? That is by Dr. Shija.
I don't know. I don't know. I'll pass on the question. As far as my practice is concerned, I have seen only 2 cases in the past 12 years. So I don't know about the incidents in Kerala. Prevalence in Kerala.
Naveen, sir.
Yeah, I'll just answering in words or numbers. Many of you were doing residency with us when we were religiously wanting to do screening for dislocatable hip. And it was a part of our discharge summaries last line, where we had to do the Barlow test to see whether the hip can get dislocated or not. And one of the major modifications we did in the Illingworth was to state that please stop doing this. Because in the Western world, when they started looking for dislocatable hips, many of them started getting referred very early to orthopedicians. They would obviously do an ultrasound, find some angles, do some x-rays and find some lines and start treating these babies with spikes. And then these babies started developing avascular necrosis of the neck, landing up in actually more damaged hips than in babies who are not being screened. So after that, the current statements are now is to start not screening in the newborn period for dislocatable hips. It is for dislocated hips. So if you are finding a hip which cannot be abducted in the newborn, it is a part of a musculoskeletal disorder, neuromuscular disorder. But that brings more responsibility to us as pediatricians now. Previously, we could look at it and say newborn person missed it, he didn't do it. But now every visit in the vaccination visit coming to the OPD in infancy, you have to look for hip abduction. It is not again dislocatable hip, it is for dislocated hip. So you look for limited abduction on each side. Please document it. And if you can't abduct the hips completely, of course, babies can be angry and hungry, then you may not be able to do it. Now coming to the commonness, we have about 1,200 deliveries in NIMS, and there was a time when we were screening everybody. Once in a year or twice in a year, we pick up hips which are just completely loose and just slip out of the hip, and what you would call dislocated hip or dislocatable hip in the newborn. But almost all others were part of existing musculoskeletal disorders. So in true hips which are dislocatable are in 20 years, that means 20,000 babies, less than 10. So maybe if you are seeing more than more than 1 in 2 years in your practice, then probably you may be picking up only clicks and clunks, and they may not be diseases which require treatments. Possible. So we may have to review our work process. This is just a thought, but I can see Jairam sir had some suggestions, please.
Jairam,
We
sir.
have Dr. Rose also a senior pediatrician. Dr. Rose, would you like to suggest? You were seeing a large number of normal newborns and sick babies.
Yeah, Dr. Rosemary suggestions regarding DDH, developmental dislocation of hip.
I have nothing more to add as such. Sir has covered everything actually. The screening is important, definitely. Early detection will definitely help in managing such cases.
The same question, how often we see DDH in our area? Is there any clue that will help us for an early diagnosis other than the usual tests? So I think
we covered most of the questions.
Yeah, and suggestion by Indumati madam. I agree with Naveen sir. Strictly holding the head by pillow may not be possible, as normal tend to move their heads. By Indumati ma'am. Next question: a baby who skipped crawling, is he at increased risk of autism? A baby who skipped crawling, is he at increased risk of autism?
We cannot say so. That is what I think, because crawling and creeping are two these things without which the next milestone can appear. That is what we have studied for years. That is, without crawling, the baby can sit, and without creeping, the baby can stand. That is the dictum. So these two milestones are not very mandatory in the baby, but we can make them do it if we see. I mean, make them do in the sense we can put them in such positions to do. It doesn't necessarily mean that those who skip these milestones develop autism. That is what I know practically. Is there any other? Sir.
Naveen sir.
I go with Hazeena completely. Just that because we have 45 people in the hall, I want them to benefit in picking up autism in their practice every time. And only one mantra. At 9 months, baby should start playing. So when they come for your measles vaccinations at 9 months or 10 months, play. And reciprocal play has to be there. Autism's the greatest problem is not a delay in any milestone. You can have a completely intelligent child with autism spectrum disorders. The problem is reciprocal interaction, play, social behavior, and milestone. So make it a rule that at 9 months, 10 months vaccination, when they come, you see whether the child is playing with you. Just show a pen, show a tape, throw a paper at him. Does he respond to you? Show a torch, does he reach out? If it doesn't, of course, it's a very early, you may just want to flag him and don't scare the parents, see him after at 1 year. But by 1 year, nobody should miss autism. So MChat is there. There are several structured tools which will be done by specialists. But as pediatricians, 9 months play has to be very, very distinctly detectable.
Pointing of fingers as well.
Anybody else want to add on to the same question? Jairaman sir, anything to be added on?
Yes, thank you, Beno.
Yes.
Regarding that question about crawling, I don't see, as Naveen said, I don't think there is an association said to be as with autism. But I remember reading somewhere, and even in the old module of Indian Academy of Pediatrics on poor scholastic performance, that there is some association with the absence of learning, absence of crawling in children with learning difficulties, which I had been seeing in my clinic for children with learning disorders as well. So this is a very commonly observed finding that these children with learning difficulties have skipped the stage of crawling during their milestones. And another thing which I like to mention is that regarding autism, one of the early indicators can be in your practice only if a child is failing to adopt an anticipatory posture when you offer the child to be taken up. that is, he doesn't want to mingle with anybody. This is said to be one of the early features of autism. In this, I have read in one of the first articles which I read on autism, which was published way back in Indian Journal of Pediatrics. I don't know what is the current status of this observation.
I think we are done with the questions. Any key points, madam, you want to stress upon? Hazeena, ma'am.
Yeah, I have.
You have covered everything, madam. Anything, any take-home message or anything, madam?
Take-home message I want to convey is that even in normal babies, please attend to the parents' behavior as well, which is a modifiable factor for improving the development of the baby. Along with observing the babies, anyway, we will observe and examine the babies, but we need to observe the parents and help them modify themselves, because development is a continuous process for both babies and us and parents. For pediatricians and parents and babies, development is a continuous process.
Naveen sir, any take-home messages?
Yeah, keep thinking about Hazeena. She has spent 1 hour to tell you that assess, document, development. The child will be safe, you will be safe. So remember, Hazeena, that every newborn comes to your OPD, think of Hazeena.
Definitely, sir.
Thank you. Thank you all.
Okay. Now, if there are no further questions, I would request our IAP THIRUVANATHAPURAM treasurer, Dr. Rosemary, to propose a vote of thanks. Over to Dr. Rosemary.
Okay, I would like to thank Hazeena madam for an excellent talk. It was very lucid and very clear in all aspects. Thank you, ma'am, for sharing your opinions. And Naveen sir, as always, had made this session very lively and very interactive, and has added a lot of important points. Thank you to Naveen sir also. I would like to thank all the senior pediatricians who joined us today in this session, especially Jain sir, Induvadi madam, who all participated also in the discussion. And I also thank all the members who joined us today for this session. I hope they all learned some important points. So thank you all, and good night.